I am Dr. Vanditaa Agrrawal and I will be presenting on the topic Parinaud syndrome in a patient with Pinealocytoma. My co-authors are Dr. Rebecca Dhiman, Dr. Himani Thakur, Dr. Swati Phuljale and Dr. Rohit Saxena. I have no financial disclosures. A 49-year-old male presented to our clinic with chief complaint of diplopia for distance, which was associated with headache and present since the past 4 months. There was no complaint of any diminution in vision, no history of any trauma, and no known systemic illness. On ocular examination, the best spectacle corrected visual acuity in both the eyes was 6/6, IOP in the right eye was 15 mm Hg and in the left eye 17 mm Hg. The anterior segment and the fundus was within normal limits. On extraocular movement examination, there is limitation of elevation in both the eyes. So when the patient tries to look up, there is limitation of elevation and also a deconjugate horizontal jerk nystagmus, which is particularly noticeable in upward gaze. Hence, the patient has upward gaze palsy and convergence retraction nystagmus. When the patient is asked to look from a distance to a near target, that is on accommodation, there is good pupillary constriction present, but on light stimulation, there is only a small reaction to light present, showing that the pupillary constriction in response to light is impaired, causing a light near dissociation, also known as pseudo-Argyll-Robertson pupils. So looking at these signs, a lesion at the level of midbrain was suspected and the patient was advised a contrast-enhanced MRI of the brain in orbit, which shows a well-defined solid cystic lesion posterior to the third ventricle centered in the pineal region, appearing hyperintense on T1 with cystic component showing suppression on flare and solid component showing homogeneous post-contrast enhancement. The pineal gland is not seen separately from the lesion. Antero-inferiorly, the lesion is seen compressing the midbrain. So a pineal gland tumor was suspected and the patient was referred to the neurology department for further management. Over there, endoscopic third ventriculostomy and simultaneous tumor biopsy was done, which confirmed the tumor to be Pinealocytoma grade 1 and the patient was further planned for tumor excision surgery. So understanding the pathophysiology of Parinaud syndrome is important. There are 3 main centers involved in the vertical gaze. First is rostral interstitial nucleus of medial longitudinal fasciculus, second interstitial nucleus of Cahill, and third posterior commissure. The RIMLF and the INC are located at the level of superior colliculus in the midbrain. The RIMLF normally projects its fibers to the superior rectus and inferior oblique, which are the elevators of the eye. It also activates the M group of cells, which then projects its fibers to the superior rectus and inferior oblique. The INC receives its input from RIMLF and then projects its fibers through the posterior commissure to the SR and IO. So there is a dysfunction in RIMLF and INC if there is a lesion at the level of superior colliculus in the midbrain, causing defect in elevation. Also, convergence retraction nystagmus is caused by damage to the supranuclear fibers which have an inhibitory effect on the neurons in charge of convergence and divergence. This lack of inhibition results in a continuous discharge of the medial rectus muscle, causing a deconjugate horizontal jerk nystagmus. Coming to the pupillary reflex pathway, normally on light stimulation, signals from the optic nerve go through the optic tract chiasma and then through the pretectal nuclei, which project to the ipsilateral and the contralateral Edinger-Westphal nucleus, from which exit the parasympathetic fibers that accompany the third nerve, causing meiosis. But in Parinaud syndrome, there is damage to the pretectal nucleus, which prevents signals from reaching the Edinger-Westphal nuclei. To ensure signal arrival to these nuclei and activation of pupillary contraction, the pretectal nuclei can be bypassed and go directly from either the cortex, or there is another mechanism in which the light causes inhibition of the sympathetic inhibition of Edinger-Westphal nuclei, causing activation of Edinger-Westphal nuclei, causing meiosis to light. Therefore, in patients with Parinaud syndrome, there is a small reaction to light when light intensity increases. Hence, it is called pseudo-Argyll-Robertson pupil. So coming to the Collier side, that is upper eyelid retraction. Normally, there are two groups of cells responsible for eyelid elevation in the midbrain. One is M group and the other is central caudal nuclear, that is the CCN group of cells. Normally, the M group activates the CCN group, which further causes eyelid elevation. Also, there is inhibitory fibers coming from the posterior commissure and the interstitial nucleus of Cahill to the M group to inhibit eyelid elevation. But as we know, in Parinaud syndrome, there is damage to the posterior commissure and the interstitial nucleus of Cahill, which causes decrease in the inhibition of M group, causing increased eyelid elevation. Another hypothesis is that any lesion in the midbrain may trigger overstimulation of the M group, causing increased output to the CCN and allowing more eyelid elevation. So the take-home message from this video is thorough clinical examination and a basic understanding of neuro-ophthalmology anatomy is essential in diagnosing and managing such clinical cases. Thank you.